You're listening to He Said, a cardiology board review series. No fluff, just facts.
This episode is about comparing valve regurgitation parameters. If you pull up the relevant figures and flowcharts for the guidelines for quantifying aortic regurgitation, mitral regurgitation, and tricuspid regurgitation, you're going to notice that the process is very similar, but the numbers are slightly different. They're just like so similar, yet so different. And there's not really a resource that compares or explains why these numbers are the way they are. And so I wanted to do that comparison for you in the hopes that this will help you understand these numbers better, and you can understand why the numbers are slightly different in AR, MR, and TR. So pull up the relevant figures or flowcharts for AR, MR, and TR severity from the guidelines, and then just listen to what I'm about to tell you. Okay. Alternatively, you can download the handouts from my website, but it may be faster for you to compare the figures from the guidelines. So in both AR and MR, having at least 60 milliliters of regurgitant volume qualifies as severe regurgitation. But why is the cutoff for EROA at least 0.4 centimeters square in severe MR and at least 0.3 centimeters square in severe AR? Because aortic regurgitation occurs in diastole, while mitral regurgitation occurs during systole, and diastole lasts longer, so you can reach at least 60 cc's of leakage even through a smaller hole of 0.3 centimeters square instead of 0.4 centimeters square. So that's a key point to remember. You have at least 60 cc of regurgitant volume qualifies you for severe regurgitation in both AR and MR, but the cutoff for EROA, effective regurgitant orifice area, is at least 0.4 centimeters square in severe MR and at least 0.3 centimeters square in severe AR, because you can reach a 60 cc leakage through a smaller hole of 0.3 centimeters square instead of 0.4 centimeters square. Next, in both MR and TR, an effective regurgitant orifice area of at least 0.4 centimeters square qualifies as severe regurgitation. But why is the cutoff for regurgitant volume at least 60 cc's in severe MR and at least 45 cc's in severe TR? Because mitral regurgitation is ejected by the left ventricle, which contracts with much greater force than the right ventricle. Through the same severe hole size of 0.4 centimeters square, the more forceful left ventricle will eject at least 60 cc's of regurgitant volume or more, while the less forceful right ventricle will eject at least 45 cc's of regurgitant volume or more. That's why in both MR and TR, the effective regurgitant area of at least 0.4 centimeters square qualifies for severe regurgitation, but the cutoff for regurgitant volume is at least 60 cc's in severe MR and at least 5 cc's in severe TR. Regurgitant fraction by the continuity equation is not a thing for TR. It's only a thing for MR and AR. The cutoffs of mild, moderate, and severe regurgitant fraction are the same across AR and MR at 30% and 50%. In other words, if the regurgitant fraction is less than 30%, then you know that you have mild regurgitation for both aortic regurgitation and mitral regurgitation. If the regurgitant fraction is more than 50%, then you know that you have severe regurgitation for both aortic regurgitation and mitral regurgitation. And then it's not used for TR. Next, the PISA radius is not part of the algorithm for aortic regurgitation severity. The PISA radius is only part of the algorithm for mitral regurgitation and tricuspid regurgitation. The cutoff for mild versus moderate is different. It's 0.3 centimeters or less for MR and 0.5 centimeters or less for tricuspid regurgitation in terms of the PISA radius. The cutoff of PISA radius for moderate versus severe is actually the same in both MR and TR, at least 1.0 centimeters. Although the threshold might seem lower in TR at 0.9 centimeters for the moderate versus severe border, in my opinion, that is a typo in the guidelines, if I may. the resolution of TEE is not smaller than 1 millimeter. So by writing more than 0.9 centimeter, that is the same as writing at least 1.0 centimeters in terms of the significant digits. So they can just standardize this by saying at least 1.0 centimeters across the board. So for practical purposes, you can just remember that the cutoff on moderate versus severe in mitral regurgitation and tricuspid regurgitation, PISA radius is the same at least 1.0 centimeters. Don't remember 0.9 and 1.0. Just remember both of them as at least 1.0 centimeters as a cutoff for moderate to severe for MR and TR. And as I said, the cutoff for mild versus moderate is different. It's at most 0.3 centimeters of PISA radius for MR and at most 0.5 centimeters for TR, for PISA radius. Now, how about the vena contracta width? The cutoffs for mild, moderate, severe vena contracta width is 0.3 centimeters and 0.7 centimeters. That's the same across AR, MR, and TR. This is the first one that's the same across all three, so thank goodness. Although the threshold might seem lower in AR, where the guidelines specify it as 0.6 centimeters for the moderate versus severe border in AR, in my opinion, just like the above case, I think it's a typo, because the resolution of TE is not smaller than 1 millimeter. So by writing more than 0.6 centimeters, that's basically the same thing as writing at least 0.7 centimeters or more in terms of the significant digits. So they should just standardize it by writing at least 0.7 centimeters across the board. So for all practical purposes, you can treat it as at least 0.7 centimeters as a cutoff for moderate to severe in terms of vena contracta width across AR, MR, and TR. Once again, AR, MR, and TR share the exact same cutoffs for mild, moderate, and severe vena contracta width, that is 0.3 centimeters and 0.7 centimeters. In terms of flow reversal in an associated artery or vein, the vessel interrogated is different. We want to see systolic forward flow in the hepatic vein for tricuspid regurgitation. We want to see systolic forward flow in the pulmonary vein for mitral regurgitation. And we want to see systolic forward flow in the descending aorta with minimal diastolic reversal for aortic regurgitation. If we don't see any of these, that tells us that that entity is there. Since MR and TR are diseases in the systolic phase, severe MR and severe TR should cause systolic flow reversal in the pulmonary vein and hepatic vein respectively, not diastolic. Okay, let me say that one more time. Since mitral regurgitation and tricuspid regurgitation are diseases in the systolic phase, severe mitral regurgitation should cause systolic flow reversal in a pulmonary vein. Severe tricuspid regurgitation should cause systolic flow reversal in the hepatic vein. Since aortic regurgitation is a disease in a diastolic phase, severe aortic regurgitation should cause diastolic flow reversal in the descending aorta. In terms of the PW Doppler of the diastolic inflow, MR uses a mitral inflow pattern and TR uses a tricuspid inflow pattern, while AR does not use any diastolic inflow pattern, which makes sense because AR does not involve an atrioventricular valve. So why are you looking towards the atrioventricular valve? In both MR and TR, an A-wave dominant inflow suggests mild mitral regurgitation or tricuspid regurgitation, whereas an E-wave dominant inflow at a certain height suggests severe regurgitation. For mitral regurgitation, an E-wave of more than 1.2 meters per second suggests severe mitral regurgitation. For tricuspid regurgitation, an E-wave more than 1.0 meters per second suggests severe tricuspid regurgitation. Next, in terms of the area of the regurgitant color flow jet, tricuspid regurgitation is the only one that gives specific volumes in centimeters squared to quantify the regurgitant jet severity, whereas mitral regurgitation uses qualitative adjectives without specific numerical cutoffs, and aortic regurgitation uses the width percent of the color flow jet in LVOT and cross-sectional area of the color flow jet in LVOT. So again, tricuspid regurgitation uses specific volumes in centimeters square or centimeters cube to quantify the regurgitant jet severity. MR uses qualitative adjectives without specific numerical cutoffs, and AR uses the width percent of the color jet flow in LV outflow tract and color cross-sectional area of the color flow jet in LVOT. So specifically, for native valve aortic regurgitation, the jet width percent in the LVOT has the cutoffs of 25% and 65% jet width for compared to the outflow tract for mild, moderate, and severe. For periprosthetic aortic regurgitation, the jet width percent in the LVOT has the cutoffs of less than 15% means mild, 15 to 30% means mild to moderate, 30 to 45% means moderate, 45 to 60% means moderate to severe, and more than 60% means severe. Next, in MR and TR, the parabola versus triangular shape of the regurgitation jet is emphasized, whereas it is not emphasized in AR. So in MR and TR, if you have a parabola, that means it's a mild regurgitation. If you have a triangle, that means it's a severe regurgitation. Meanwhile, the faintness and density of the CW jet holds true across AR, MR, and TR. So including in AR, when you have a faint jet on CW Doppler, that means it's a mild regurgitation. When you have a dense jet, that means it is a severe regurgitation. That holds true across AR, MR, and TR. Pressure half time is not part of the algorithm for MR and TR severity. It's only in AR. Mild AR has a pressure half time of more than 500 milliseconds. Severe AR has a pressure half time of less than 200 milliseconds. This is in the opposite direction as in mitral stenosis, where in mitral stenosis, severe MS has a pressure half time of more than 150 milliseconds. So remember that in mitral stenosis, longer pressure half time is worse, more severe, whereas in regurgitation, aortic regurgitation, a shorter pressure half time is more severe. Okay, so mild AR means mild AR has a pressure half time more than 500 milliseconds. Severe AR has a pressure half time less than 200 milliseconds, whereas in the opposite direction for severe mitral stenosis, that has a pressure half time of 150 milliseconds. And again, MR and TR severity do not use pressure half time as part of the algorithm. Only aortic regurgitation does. Flail leaflet or poor leaflet coaptation points to severe AR and severe MR. Leaflet morphology is not officially part of the algorithm for TR severity. It is part of the decision tree for deciding if TR is primary or secondary, but not part of the algorithm for TR severity. In AR, we care about LV dilation. In MR, we care about LA or LV dilation. And in TR, we care about RV dilation. Now that we have all of these concepts down, how do the flowcharts differ? In terms of the criteria of the boxes that point to, quote, definitely severe regurgitation, certain things are present only in one valve. Pressure half time less than 200 milliseconds is only present in the criteria for definitely severe aortic regurgitation. Large flow convergence is only present in the criteria for definitely severe aortic regurgitation. Dense, triangular, CW Doppler jet is only present in the criteria for definitely severe tricuspid regurgitation. Certain things are absent only in one valve. The PISA radius is not part of the algorithm for AR severity, just MR and TR. Certain things hold true across the board for AR, MR, and TR. Vena contracted width of at least 0.7 centimeters is a criterion for definitely severe. See my explanation above about why 0.6 centimeters greater than 0.6 centimeters is the same as greater or equal to 0.7 centimeters for practical purposes on TEE. The other things that hold true across the board for AR, MR, and TR are flow reversal. So systolic flow reversal for MR and TR, diastolic flow reversal for AR in a pulmonary vein, hepatic vein, and descending aorta respectively is a criterion for definitely severe regurgitation. Having a large central jet is a criterion for definitely severe, meaning more than 50% of the regurgitant receiving chamber for MR and TR and at least 65% of the LVOT width for AR. This is a criterion for definitely severe. Presence of flail leaflet, or in the case of tricuspid regurgitation, no coaptation, is a criterion for definitely severe. LV, or in the case of TR, RV, dilation with normal function is a criterion for definitely severe. These are the things that hold true across the board for AR, MR, and TR. Now, there are also criteria for boxes that point to definitely mild regurgitation on the left side. Certain things from the severe boxes are not present in any of the mild boxes. Flail leaflet is not part of the box for definitely mild regurgitation since the absence of flail leaflet could mean moderate or mild. Certain things from the mild boxes are not present in any of the severe boxes. Diastolic inflow, meaning an A-dominant mitral inflow for mitral regurgitation and an A-dominant tricuspid inflow for tricuspid regurgitation, is part of the box for definitely mild regurgitation for MR and TR, but they decided not to use the corresponding criteria in the box for definitely severe regurgitation, i.e. an E-dominant mitral or tricuspid inflow with an elevated E. They didn't use that in the box for definitely severe regurgitation. Certain things are present only in one valve. A pressure half-time more than 500 milliseconds is only present in the criteria for definitely mild AR. Small or no flow convergence is only present in the criteria for definitely mild AR. Systolic predominant hepatic vein flow is only present in the criteria for mild TR. They must have decided that the negative predictive value of flow reversal is not good enough for AR and MR and excluded it from the definitely mild regurgitant box. Certain things are absent only in one valve. PISA radius is not part of the algorithm for AR severity, just MR and TR. Diastolic inflow A dominance is not part of the algorithm for AR severity, just MR and TR, which makes sense since diastolic inflow pattern is not pertinent to aortic valves. Certain things hold true across the board for AR, MR, and TR. Vena contracta width of less than 0.3 centimeters is a criterion for definitely mild. Small central jet is a criterion for definitely mild. Soft or partial CW jet is a criterion for definitely mild across the board, whereas for the definitely severe regurgitation boxes, they only included dense CW jet as that definitely severe regurgitation for TR, but not for AR and MR. And normal chamber size, which refers to LV for AR, LV and LA for MR, and RV and RA for TR, is a criterion for definitely mild across the board. Then for the criteria boxes for the quantitative measures, across the board for AR, MR, and TR, regurgitant volume, regurgitant fraction, and EROA are used for quantitative differentiation of regurgitant severity, except in TR, where there's no practical way to do regurgitant fraction, so vena contracta width, which is technically considered a semi-quantitative, not a quantitative variable, is used in place of regurgitant fraction so that there can be three things to break the tie. Now, we'll end by going over a few other points in terms of common principles in quantification of valve regurgitation. As flow converges towards a restrictive orifice, fluid dynamic principles show that a series of isovelocity shells with smaller area or radius and higher velocity are formed. When doing PISA, if the regurgitant blood is going up on your screen, i.e. towards the probe, then you need to adjust your baseline up. If the regurgitant blood is going down on your screen away from the probe, then you need to adjust your baseline down. You do not shift the baseline for vena contracta, you only shift the baseline for PISA, and then you need to remember to shift it back. Under measuring the PISA radius will lead to underestimation of the EROA, effective regurgitant orifice area. The aliasing velocity itself will not affect the calculated EROA, but failing to decrease the aliasing velocity will make the PISA radius smaller and more prone to measurement error. The optimal aliasing velocity for PISA is 30 to 40 centimeters per second. If you use aliasing velocity much higher than 40 centimeters per second, your PISA radius will be overly small. If you use aliasing velocity much lower than 30 centimeters per second, you will pick up an isovelocity shells too far from the regurgitant orifice, where the surface no longer has the shape of a hemisphere. PISA should be measured in any view that allows for optimal Doppler alignment. PISA should be measured at the peak mitral regurgitant velocity or tricuspid regurgitant velocity, which usually occurs close to the T wave on ECG. Quantifying eccentric jets. While jets may appear significantly smaller for an eccentric jet compared to a central jet, since the eccentric jet gets flattened by this receiving chamber wall, the vena contracta approximates the regurgitant orifice, which is not impeded by the eccentricity of the jet. The vena contracta for a fixed orifice is independent of flow, rate, and driving pressure across the valve, unlike jet area. However, if the regurgitant orifice is dynamic, the vena contracta may change with hemodynamics or during the cardiac cycle. The vena contracta is characterized by high velocity and laminar flow, not turbulent flow. The vena contracta is slightly smaller than the anatomic regurgitant orifice due to boundary effects. Regurgitant jet area is highly sensitive to technical factors such as gain, output power, and Nyquist limit. The vena contracta is considerably less sensitive to technical factors such as PRF compared to the jet in the receiving chamber. That is all for common principles in quantification of valve regurgitation and the larger section earlier on comparing valve regurgitation parameters. I think this is a relatively unique episode in that we're comparing the numbers from 3 different sets of flowcharts and the guidelines, and I really hope that this will help you better understand the differences in quantification of the regurgitation severity for AR, MR, and TR.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.